In this video, we are going to discuss about Myasthenia Gravis. Myasthenia Gravis is an autoimmune disease of the neuromuscular junction. Is characterized by varying degrees of weakness of the voluntary muscles that worsens with activity. Myasthenia gravis can cause muscles to feel weak and get tired quickly. It can affect many muscle groups, but it's more common in the eyes, face, throat, neck, arms, legs, and respiratory muscles. Most likely will be the first sign something is wrong is eyes. Throat is another common sign, hoarse voice and problems swallowing. Face, neck, arms and legs. The patient with the severe cases, the respiratory muscles for breathing also is affected. Pathophysiology. Normally, a chemical impulse precipitates the release of acetylcholine from vesicles on the nerve terminal at the myoneural junction. The acetylcholine attaches to receptor sites on the motor and plate and stimulates muscle contraction. Continuous binding of acetylcholine to the receptor site is required for muscular contraction to be sustained. In myasthenia gravis, the issue arises at the neuromuscular junction. This is the place where the motor neuron and the muscle fiber meet and the neurotransmitter acetylcholine is released. At this junction are receptors on the muscle fiber called nicotinic acetylcholine receptors that become stimulated when acetylcholine is released and cause contraction of the muscle fiber. Antibodies directed at the acetylcholine receptor sites impair transmission of impulses across the myoneural junction. Therefore, fewer receptors are available for stimulation, resulting in voluntary muscle weakness that escalate with continued activity. However, in myasthenia gravis, the nicotinic acetylcholine receptors are being attacked by antibodies the immune system has created and are not working properly. These receptors cannot assess the release of acetylcholine and cause muscle contraction, so there is muscle weakness. Thymus gland, which is found anteriorly in the upper part of the chest behind the sternum in between the lungs, plays a very important role in our immune system health. It's a creator of T cells, which are super important for immune health by fighting viruses and bacteria. In children, the thymus gland is very large. Remember, it will produce most of the body's T cells by the time a person attains puberty. It should shrink by adulthood and then in older age be like a fatty tissue. But in people with myasthenia gravis, the thymus gland tends to stay large and develops tumors or collection of immune cells in the gland. It is thought that the thymus erroneously causes immune cells to produce antibodies that will attack receptor sites on these voluntary muscle neuromuscular junction. These antibodies are found in 80% to 90% of people with myasthenia gravis. Of people with myasthenia gravis, 75% have either thymic hyperplasia or a thymic tumor, because the thymus gland is believed to be the site of antibody production. The patient's blood cells and thymus gland produce antibodies that block, destroy, or weaken the neuroreceptors that transmit nerve impulses, causing a failure in transmission of nerve impulses at the neuromuscular junction. Now we'll see signs and symptoms. Muscle weaknesses become worse with activity, especially repetitive activity, but will improve after resting the muscle. Patients tend to notice symptoms in the eye due to eye muscle weakness of the extraocular muscles or have problems with speaking or slide or swallowing. Signs and symptoms may vary among patients. Initial manifestation involves ocular muscle weakness. Example, diplopia and ptosis. Eyelid drooping can be one eye or both eye. Extraocular muscle involvement leading to double vision, that is strabismus. Patient will have laryngeal involvement, dysphonia, voice impairment, and increase the risk of choking and aspiration. Slurred speech, voice may be hoarse and very soft. Many muscles which involve swallowing process will be weak. Because of that, the patient may have choking or gagging when eating. Weakness of the muscle of the face resulting in a bland facial expression and a throat that is bulbar symptoms. Weakness of neck, face, arms, legs, hands and generalized weakness may present in the patient with myasthenia gravis. Patient may have mask-like appearance. There won't be any expression, looks very sleepy. The patient may be very weak, very fatigued, no energy. It may get worse throughout the day as muscles are used. Generalized weakness that affects all extremities and the intercostal muscles, resulting in decreasing vital capacity and respiratory failure, short of breath, can extend to respiratory muscles. Diagnostic evaluation. First, we have to see the diagnostic assessment. History and physical assessment to be done with the patient with myasthenia gravis. Fatigability with prolonged upward gaze, that is 2 to 3 minutes. The patient may have muscle weaknesses. Electromyography is to be done with the patient with the myasthenia gravis to help diagnose injuries and conditions that affect the muscles and the nerves that control them, such as carpal tunnel syndrome and muscular dystrophy. The thymus gland, the site of acetylcholine receptor antibody production, may be enlarged in myasthenia gravis and may be identified by MRI scan. Hydrophonium or Tensler test also to be done with the patient with myasthenia gravis. During this test, a medication is given called hydrophonium. How does the medication work? It prevents the breakdown of acetylcholine at the neuromuscular junction, which allows more of the neurotransmitter to be present at the neuromuscular junction. It is used to diagnose myasthenia gravis and differentiate between a myasthenia crisis and a cholinergic crisis. Patient with myasthenia gravis or patient with myasthenia crisis, the signs and symptoms will temporarily improve. The test will be positive. The patient with the cholinergic crisis, if we give hydrophonium, the signs and symptoms will become worse. No improvement. The test will be negative. If the signs and symptoms become worse by giving hydrophonium, the nurse will administer the antidote of hydrophonium, that is atropine. It is also important to have the patient on a cardiac monitor during the test and a crash cart within reach if emergency arises. Management of myasthenia gravis is directed at improving function and reducing and removing circulating antibodies. Oral anticholinesterase drugs such as neostigmine and pyridostigmine are first-line treatment for mild myasthenia gravis. It provides symptomatic relief by inhibiting the breakdown of acetylcholine and increasing the relative concentration of available acetylcholine at the neuromuscular junction, enhancing neuromuscular transmission. Inadequate dosing can cause myasthenic crisis. Excessive dosing will cause a cholinergic crisis, which occurs due to much cholinesterase inhibition. In a cholinergic crisis, giving hydrophonium increases muscle weakness. The use of corticosteroids in addition to hydrophonium have reduced the incidence of cholinergic crisis. Immunosuppressive drugs such as prednisolone are the mainstay of treatment when weakness is not adequately controlled by anticholinergic medication. Azathioprine may be added as a steroid agent. Immunosuppressant treatment is often permanent. Plasmapheresis removes antibodies from the blood and is used for patients in myasthenia crisis or for short-term treatment of patients undergoing thymectomy. IVIG is also an option and has less side effect. Surgical therapy. Thymectomy is indicated for patients with a tumor or hyperplasia of the thymus gland. Because the thymus gland in the patient with MG appears to enhance the production of acetylcholine receptor antibodies, removing the thymus gland causes improvement in most patients. A few patients achieve a cure after thyroidectomy. Interventions for myasthenia crisis. Immediate hospitalization and may require intensive care. Hydrophonium to differentiate crisis and treat myasthenic crisis. Because of hydrophonium treatment, temporarily worsens cholinergic crisis. Sometimes the patient may have bradycrisis. It occurs when the receptors at the neuromuscular junction become insensitive to anticholinesterase medication. We must manage airway, mechanical ventilation, vigorous suctioning, oxygen therapy, postal drainage with percussion and vibration. Tracheostomy may be required depending on duration of intubation. Maintain semifowler's position, especially in obese patients. Plasmapheresis, IVIG, and high-dose parentally administered corticosteroids are used to reduce symptoms. Plasmapheresis must be carried out before IVIG therapy because plasmapheresis will remove the IVIG proteins that are effective in symptom reduction. Neostigmine IV for myasthenic crisis. Discontinuation of anticholinergic medications until respiratory function improves. Atropine to reduce excessive secretion for cholinergic crisis. There is no cure for myasthenia gravis. Treatments do not stop the production of the acetylcholine receptor antibodies, but it will reduce and remove the circulating antibodies. Next, we will see the difference between myasthenia crisis and cholinergic crisis. Myasthenia crisis happens due to excessive stimulation at the neuromuscular junction by acetylcholine. It is too much acetylcholine available in neuromuscular junction, which leads to overdrive in cholinergic response. In cholinergic crisis, it happens due to low to no stimulation at the neuromuscular junction by acetylcholine. Receptors are not available to do their job because of antibodies attacking the receptors, which leads to severe muscle weakness. Causes of myasthenia crisis are it is because of over-medication of anticholinesterase given in MG. These medications stop the breakdown of acetylcholine, so there is more available at the neuromuscular junction. This is great for treating myasthenia gravis, but too much of the medication can cause cholinergic crisis and the overstimulates the muscle fiber where it will eventually quit contracting. The causes of cholinergic crisis are it is because of the insufficient amounts of anticholinesterase drug or an illness, that is respiratory infection, stress, etc. that has created exacerbation of the disease myasthenia gravis. Signs and symptoms of myasthenia crisis is muscle fibers have had enough of the stimulation, so they quit responding to the impulse, which will lead to respiratory failure and muscle weakness. However, other signs and symptoms that will present are similar to parasympathetic stimulation, that is rest and digest system, but in overdrive. The patient will have GI issues, vomiting, diarrhea, cramping, pupil constriction, increased salivation and tear production. The patient will have blurred vision and increased respiratory secretions. The patient will have muscle fasciculation, twitching from overstimulation. Then eventually the patient will become paralyzed. The patient will have low BP and heart rate. Signs and symptoms of a patient with a cholinergic crisis. Remember, no receptors are available to receive the acetylcholine, so there is no stimulation of the muscle fiber, which leads to no contraction but flaccidity. In both conditions, the patient will have respiratory failure and muscle weaknesses. However, signs and symptoms will affect all voluntary muscles, making them flaccid from eyes to bowels. Pupils will be dilated. Patient will have tachycardia, hypertension, no cough or gag. Patient may have aspiration because the patient cannot swallow or cough. The patient will have incontinence because of no muscle strength of both bowel and bladder. The patient will have to undergo Tensilon test. Edrophonium is given to the patient, that is an cholinesterase inhibitor. This will cause the patient to experience even more weakness if the patient is having myasthenia crisis. Adding more acetylcholine at this site, it is not needed because there is already enough acetylcholine at the neuromuscular junction site, causing overstimulation. The patient's signs and symptoms will not respond but become worsen. Finding the result will be negative. In cholinergic crisis, the Tensilon test will be positive. Edrophonium is given, which is an cholinesterase inhibitor, and this will cause the patient to experience improved muscle strength, adding more acetylcholine to the neuromuscular junction because it inhibits the breakdown of acetylcholine. Signs and symptoms temporarily will diminish. In myasthenia gravis, we have to hold anticholinesterase medication, administer atropine, that is antidote per MD order. Treatment for cholinergic crisis. Give more anticholinesterase medication for cholinergic crisis.